Hello and welcome to the first in a series of webinars looking at the care of the hematology patient during the COVID-19 crisis. This first webinar is brought to you jointly by the EHA and the EBMT, and our topic today is sharing experiences in treating hematology patients undergoing intensive treatment during the COVID-19 crisis. Now, as the viewer, you'll be able to submit questions yourself, but in the interests of time and getting through them all, it's likely that after the webinar is over, both the EHA and the EBMT will collate your questions and further follow them up. They may even shape future webinars in this series. So today I'm joined by four speakers who will be tackling these questions, and I'd like to introduce them now. Firstly, we have Professor Alessandro Rambaldi from Italy. We have Professor Josep Ribera from Spain, Professor Marie von Lilienfeld-Toal from Germany, and Professor Malgorzata Mikulska from Italy. So, without further ado, if we could start the webinar with the first question. And the first question is going to be taken, the questions are going to be taken in pairs. So Professor Ribera and Professor Rambaldi will be taking the first question between them, and they'll spend a few minutes each answering them. So the first question to you, Professor Ribera, is what are your views on the treatment of COVID-19 patients with hematological malignancies and transplanted patients? And that's over to you, Professor Ribera. Thank you.
Good afternoon. In order to not delay, is this the first slide available, please? Okay, I'll try to explain my view in the treatment of coronavirus infection in hematological malignancies, and my colleague from Italy will discuss in depth the problem of transplanted patients. So, as a general principle, we have to take into account if coronavirus infection is higher, the incidence is higher than in general population. So there is a scarce information on that, but the most solid comes from China and show an odds ratio of 2 times of probabilities of having coronavirus infection in patients with malignant hematological diseases. Now we have to consider by beginning the therapy, we can split the patients who are newly diagnosed or who are under treatment when COVID infection is detected. For newly diagnosed patients, it's mandatory in our hands to have a PCR study for coronavirus infection and defer the therapy if the patient is clearly positive. If the patient is under treatment, the most important thing is to detect quickly the presence of this virus, and any patient with fever or compatible symptoms, even without fever, have to be submitted to PCR study. There are general measures that are very, very important in these epidemics. The most important is the intensive hygienic measures, not only at hospital, but also at home. And one of the important visits that this is a trouble for the patients, but avoiding visits is a requisite to one of the requisites to stop the spread of this virus. So our main effort is to maintain the hematologic units COVID-free in order to give the intensive therapy as intense as planned, at least for conventional therapies. The problem of transplantation will be treated later. And also for many reasons, but it's clear that the therapy that is not strictly necessary should be restricted especially in the peak of coronavirus incidence. So I have made a detailed rules for patients with some specific hematologic diseases. So for aggressive lymphomas, we don't change the initial therapy that is R-CHOP in most countries, and to give this therapy as outpatient as possible. And very important to replace the visits by telemedicine. So restrict the going patients to the day hospital. For rescue therapy, the same principles are applied, and for transplantation, perhaps differ, at least in the outbreak of COVID infections. That is the situation in Spain. So for indolent lymphomas, use the watch and wait approach as much as possible, and avoid bendamustine. At least we do this, and defer the onset of maintenance with rituximab at the peak of coronavirus infection. And for mantle cell lymphoma and CLL, use ibrutinib as an oral drug, and avoiding the visits of the patients in hospital. For Hodgkin's lymphomas, we avoid the use of radiotherapy because there are multiple sessions and multiple visits of the patient to the hospital. So to avoid this, and use telemedicine as much as possible. And also defer transplantation as much as possible. For patients with acute leukemias, the situation is different. For ALL, it's mandatory to detect that the patient is COVID negative before therapy. We proceed with our standard therapy, and when the patient is out of hospital, we restrict the control visits. In relapsed patients, we prefer inotuzumab over blinatumomab in order to be less immunosuppressant. And regarding transplantation, we have to try to adapt at the best time possible. For AML, we use the standard induction, but extending the prophylactic measures, and the same as ALL, when the patient is in CR, try to use the day hospital for consolidation and the hospital at home for this purpose. For MDS, is the same, to limit the transfusions as strictly needed, the use of erythropoietic stimulating factors, and defer the use of hypomethylating agents when this is strictly indicated. Well, for chronic myeloproliferative neoplasms, CML should be treated as usual, and for the remaining chronic myeloproliferative neoplasms, all the drugs are possibly being given to the patients, and perhaps the only thing is to defer the initiation of JAK inhibitors therapies. But if the patients are taking these JAK inhibitors, we don't skip them to avoid the rebound symptoms. So, and again, telemedicine, and especially control the risk of thrombosis in these patients, because coronavirus is also associated with increased risk of thrombosis. And for myeloma, we do not change the initial therapeutic approach, and the same for maintenance. And use as much as possible remote labs and telemedicine, and also delaying the stem cell transplantation, because we can we can give more cycles of therapy, of triplets of therapy, for example, before the autologous transplantation. So, well, and that's all. The most important is also to follow the rules of each specific society. For example, a Spanish Society of Hematology has given rules for the diseases. The American Society of Hematology has also provided rules. The EHA, the EBMT have rules, and we have to make a quick, a periodic consultation in order to update our clinical and modify our clinical approach to the patients. Thank you.
Thank you, Professor Ribera. A really, really comprehensive summary there. On to Professor Rambaldi, and just in the interest of time, I know there's so much information to get across, but 5 minutes would be fantastic if you can stick to that. Thank you. Professor Rambaldi, all yours.
Hi, well, good evening, everybody. I'm talking to you from one of the epicenter of this COVID crisis in Europe, from the Bergamo hospital. If I can have the next slide, please. And this is just to show which was the unbelievable behavior of this outbreak in our hospital. Starting from February the 20th, you see the enormous increase of the patients who need to be hospitalized. And we reached a stable number around 500 patients. So the comment to this outbreak is that the main problem, in my understanding, for COVID is to be prepared to manage this dramatic situation. Next slide. And so the first problem was that we were asked to preserve the hematologic activity of the ward, so the inpatient and the outpatient ward. But we were asked also to give half of our physicians and nurses to assist the many patients who were coming into the hospital. So there was some reduction on the standard hematologic activity. Yes, you see that there was a decrease in the first consultation. That means that many patients have been disregarded in this first month of the crisis. And there was also a reduction in the current outpatient clinic as far as the chemotherapy treatment were planned in comparison to last year. Next slide. Actually, this did not occur for some diseases, particularly acute myeloid leukemia and multiple myeloma. Those patients did not decrease in their referral to our hospital, and we took care of them. They were all COVID negative, so we didn't change our common practice in delivering the care. Of course, we believe that many patients have missed. I mean, we missed many patients for the simple reason that the region, the lockdown, the hospital lockdown. So it's very likely that in the next few months, we will see many patients coming back to the hospital, probably in a bad clinical condition. Next slide. One important thing is to know whether the transplant activity was reduced during these days. This was not the case. As you can see from this slide, in comparison with the activity done in 2019, there is no significant difference in the total amount of patients who were admitted to the transplant unit for either the autologous or the allogeneic stem cell transplantation. Of course, we had to face many problems. At the beginning of the outbreak, when many people were thinking that this was mainly an Italian problem, we had to face some additional problems with the courier from all over the world, and particularly from Germany, that is the main provider of allogeneic stem cell donors. Now the situation has been stabilized. We have found a suitable solution to manage and to plan allogeneic stem cell transplant activity. And I'm happy to say that in Italy, during the first 3 months, the overall transplant activity has not declined. So that means that if you put in place a good organization, you can have and you can preserve your standard of care activity. That's all for the first part of my presentation.
Thank you very much indeed. So that was a great summary on that first question about the treatment of patients with hematological malignancies and transplants. Moving on to question 2. So this is a question that is going to be dealt with our other 2 speakers, Professor Marie von Lilienfeld-Toal and Professor Malgorzata Mikulska. The question is, according to your experience, would you recommend specific means to prevent COVID-19 for hematological malignancies and or transplanted patients in hospital and in practice? And did you see any particular increase in the incidence of COVID-19 infection in patients who underwent an intensive chemotherapy program or an autologous or allogeneic transplantation? So Professor von Lilienfeld-Toal, if you would like to answer that first, please.
Yeah, thank you. If I could have my slides, please. So the answers I'm going to give on how you might prevent a severe course of COVID disease are sort of based on the recommendations we came up with in the EHA Infectious Disease Working Party. And really, some of us have been working on respiratory viruses for quite a while. So we deduced some of these recommendations from other respiratory viruses. And my first 3 points here are more sort of organizational, and I know that Professor Mikulska will comment on these points more in detail. So I'd really reinforce the 4th point, which is that patients should ideally be in as good a general health as possible. So they should be well nourished and should not suffer from arterial hypertension at the moment and should not have any deficiencies or any other acute problems, and be in good physical health if possible. Next slide, please. Now, we as doctors, obviously, we want to do things for people, and one reflex could be, can we give them intravenous immunoglobulins? And you could do that just to give them a good immune status, as it is recommended by the EMA for people who have very low immunoglobulins and have recurrent infections. However, you need to be aware that they obviously don't have any specific antibodies, so they're not effective specifically. It's only against any other infections, which might become a problem. Now, because we know that other super infections will be a problem, there may be a reflex to provide some additional antimicrobial prophylaxis. But we actually strongly recommend against that, and I'll show you some data why that might not be a good idea. And also we think that GCSF should be used as it is recommended in guidelines and not any more than that. We do recommend vaccination against seasonal influenza and pneumococci because that may actually provide protection against super infections as well. Next slide, please. As I said, this is to provide you some of the data why prophylactic antibiotics might not be a good idea. This is a retrospective analysis of 90 patients who received a stem cell transplantation, and they had an infection with a respiratory virus. And it was shown that if they had previous antibiotic exposure, that was actually an independent risk factor for a worse outcome in terms of lower respiratory tract infectious disease. Next slide, please. One thing I'd like to mention what we think is that a general protection against infections and probably also against COVID-19 is the control of the underlying disease. And I think this is really important because it puts clinicians under the pressure to ensure the control of the underlying disease in really very difficult situations. And this is a study we did with almost 500 myeloma patients. And really the most important multivariate risk factor for infections was the load of disease. So I think this really is an important point. Now, to just quickly comment on the question whether cancer patients are more prone to infections with SARS-CoV-2, I'm not sure we can really say that because there's still a lack of data and we don't have enough to comment on that with certainty. But it doesn't seem that they're overwhelmingly predisposed to that infection. So it doesn't seem that they really are the majority of people who are infected or anything like that. But I think it's still too early for that yet. That's my part. Thank you.
Thank you very much. Very interesting indeed. Thank you so much. And for the second answer to that question and possibly the second part, Professor Mikulska, over to you, please.
Good afternoon. I speak to you from Genova, Italy. We have currently 300 patients that are admitted to our hospital, and less than 3% of all the COVID patients had hematological malignancies. So I think that it confirms the idea that we are all susceptible, and hematology patients, they might have a slight advantage. Please do the next slide. Because I think that they are much more used to preventive measures that are very important for COVID-19, such as strict adherence to hand hygiene, to the mask use, and to isolation. So I think it's very important to reinforce these points with these patients. And just a few practical tips. You will need to become an expert on the mask use because you will get every week a different kind of mask. And they are usually divided into surgical and higher protection respirators like P2 or P3. And surgical masks, they protect from transmitting the virus from a person who has the virus and the symptoms, while P2 and P3 protect, like in case of tuberculosis, caring for patients with tuberculosis, they protect from getting the virus or the bacteria. So just pay attention, for example, that if you use, or if a patient uses P2 or P3 mask with an exhalation valve, it's usually not protecting the other people in the room from getting the virus from the patient wearing the high efficiency respirator. So we need to be very clear which mask is for whom and when. Another important one is social distancing. And well, they should avoid gatherings, public transport, of course, but we should help social distancing by precisely scheduling their appointments so they do not stay in the same room for a long time. And we should give them space to have the 1-2 meter distance, which is the safe distance for COVID infection. Some of the patients will be counseled to stay in home isolation. In Italy now there's lockdown, so almost everyone stays in home isolation. But I think it's very important to educate the patients and provide reliable written instructions about these measures so they can consult them when they are in doubt, because they will ask you questions like which product should I use for surface cleaning, or how to isolate if my husband or wife, they have symptoms or they work in healthcare. So I think that as healthcare providers, we need to be prepared to answer these questions. And the last point is that there might be a shortage of personal protective equipment, like masks, for example. Luckily, the shortage of alcohol solution can be easily solved with the use of soap and water, but providing masks for patients might be very important. To the next slide, please. The other part is how to prevent transmission occurring in the healthcare. So that's what Professor Rambaldi was saying about being prepared for the things. So currently we do nasopharyngeal swab with the results before admission for all patients admitted to hematology. and people should know how to do it properly. And there are films and pictures to show how to properly take a nasopharyngeal swab. In case of urgent admission, we treat the patients as if they were positive. And it's very important to plan if you have a patient that you need to admit overnight in a ward and you do not have the result. It will always happen on Friday afternoon or Saturday, so you should be prepared well in advance. And you should get them isolated, of course, in a single room. You should know if you can switch off your positive pressure, for example, because if you leave on the positive pressure, the virus goes out from the room. And still that the patient can be cared for by hematology team so they can provide good care. For outpatients, of course, telephone triage and triage upon presentation prevent patients with symptoms getting close to other patients. And we should prepare adequate space for many symptomatic patients, preferably, if possible, with oxygen. And they should be available both for outpatients and maybe for inpatients if they need to be transferred. And the aim of these preparations are to avoid sending hematology patients to the general emergency room for COVID-positive patients, where they can get the infection if they don't have it on admission. Next, please. My last point would be on preventing getting the infection in healthcare staff. And you should, I know it's very simple, but inform and educate in the use of personal protective equipment. And it's always a good idea when they care for a patient who is positive, for example, that you pair one nurse or one doctor who is experienced in using PPEs to supervise the first time someone who has been trained but is not that experienced. Of course, any healthcare personnel, and I highlight any person taking care of the patient or the ward with any symptoms should stay at home or work in other units without patient contact if it's not possible, and pay attention to symptoms that are not very well, they are specific, but maybe has been a little bit overlooked at the beginning, like myalgias or a loss of smell or taste, which can be very symptomatic for having COVID-19 infection. Of course, we should try to diagnose early with swabs for symptomatic staff, and if possible, also for asymptomatic. Currently, we do it only for those exposed to COVID-19. We don't do it routinely. We should plan for staff shortage, and you can leave some telemedicine, some phone visits to those who have symptoms or even those who are COVID positive, but they are well and at home. They will be probably willing to help the colleagues that stayed in the hospital. And let's not forget that many healthcare workers, they got infected from their colleagues or other staff. So it's very important to keep the appropriate distancing and using the mask, not only when you interact with the patients, but particularly when you interact with the colleagues. So during meetings in common areas, such as coffee areas, for example. There is still no data on prophylactic administration of hydroxychloroquine or antivirals to prevent the infection. So this is not the way to go. And I would just like to highlight in the end that most healthcare workers who got infected, they got infected caring for a patient who was subsequently diagnosed with COVID. So why they were not using their personal protective equipment. So correct use of these should prevent a lot of infections. Thank you very much.
Thank you very much indeed, Professor Mikulska. Some really useful practical tips there. Just briefly before we move on to the next question, Professor Ribera or Rambaldi, do you have any comments on those replies, those presentations?
I think that all the measures to prevent or to the spread of the infections, not only for patients but also for physicians, are really with a big sense. No, the one thing that is striking to me is that in Bergamo, in the center of the epidemics, the transplant team has not lowered their activity. So it's different from our recommendations in Spain, is to delay not the non-urgent transplantations, because perhaps we are 1 week later than in Italy, so we are now in the maximum outbreak of COVID infection, and perhaps in Italy you are in the plateau phase, but the problem of COVID infection in Spain is now dramatic and prevent us to initiate transplantation, not for problems in the transplantation unit, but also for the if the patient requests ICU intensive units, because all of them are saturated by patients with COVID. What's your opinion, Professor Rambaldi?
Well, I think that we, of course, limited ourselves, although the number were comparable to those of the last year. So what I would like to emphasize is that every hospital should preserve the clean area for the care of hematological patients. This is something that deals with what I would like to emphasize is the be prepared and to preserve the medical world and the doctors and some of the nurses to keep going to treat the hematological patients. This is something that is easy to be said. In practice, when you have to face such a catastrophic wave of an outbreak that may be very difficult to be put in place. But this is something that should be done, because there are patients in which we can delay the transplant, we can delay the treatment, and of course this is what we do. But there are others in which the transplant or the beginning of the chemotherapy program for an AML cannot be delayed. And if you do not have a well-preserved, clean space, well-controlled with the molecular testing for both the operators, the physician and the doctors, then you can get in trouble. So far, this was not the case in Bergamo, despite the dramatic outbreak that we had to manage.
Okay, thank you very much indeed. So let's move on to question 3, which should be on your screens now. Do you or did you recommend postponing curative chemotherapies or hematopoietic stem cell transplantation, and also sharing your experience in treating COVID-19 positive patients and negative patients with hematological malignancies? So that's over to Professor Ribera, please. Thank you.
Okay, next slide, please. Next, yeah. So to decide to postpone therapy, we have to consider several principles because there are different country by country. First is the situation of COVID infection in a specific country and even in a specific geographical area. The second is to know what is the prospects for our epidemiologist colleagues in order to prevent in what moment of the epidemics we are. So another thing is to know which is the situation of the specific hospital, which is the COVID pressure, and more important, at least in our current situation, is the availability of beds of intensive care unit. So also is important to know very well the situation in the hematology unit and even the possibility of treatment of COVID patients in other areas of the hospital, well preserved and by charge of hematologists, but to avoid an outbreak of COVID in the hematology unit. So other important thing is to know which is the possibility of deferral, other non-strict chemotherapeutic activities in the hospital, in order to avoid multiple visits of patients to this potential focus of a spread of infection. So very, very important is a close contact with our colleague with infectious diseases because they have more experience in manage COVID patients because they have a lot of patients now in our hospital, and the availability of using antiviral drugs or including patients in clinical trials on COVID. And especially, and I have to stress it, we have to need a backup of physicians and nurses. Nurses is more difficult, but part of my team is working at home with telemedicine, so contacting the patients by telephone in order to substitute the presence in the hospital of all team, because the rate of infection of physicians in our setting is 12%. Next, please. Next slide, please. So what have been done in my institution? Deferral supportive therapies for outpatients, deferral supportive measures not essential, intravenous iron and other things, to make the blood analysis remote at primary medicine, and favoring the supply of oral drugs outside hospital. So for patients with indolent lymphomas, as commented, extreme the watch and wait policy, and delay the onset of rituximab as maintenance in follicular lymphomas. You treat the myeloma patients with strict CRAB symptoms, not with doubtful symptoms. In MDS, we delay the onset of azacitidines until clearly indicated. The same for JAK2 inhibitors. Of course, use telemedicine. Now we have reduced the activity of our day hospital by 60% using telemedicine, and derivation of patients with fever, not staying at the hospital, but going to the emergency department where there is a COVID unit, and a strict limitation of visits of patients during the stay in outpatient unit. Next, please. Next slide, please. What we do in inpatient patients. So the general principle is to preserve our unit of COVID infection. It's our main goal. So all patients with fever are tested for coronavirus. We and not only once, but also several times if clinical if clinical course suggests. And if it's COVID positive, consider transfer to another specific area of hospital attended by hematologists in close contact with our colleagues of internal medicine or infectious disease. But the main way of entrance of patients to hospital is the emergency, and at that time we test any suspicious patient, and we do not transfer to another part of the hospital unless we know exactly what is the PCR result. So the visits to the patients are strictly prohibited. I am sorry for that, but this is very important because we are in the peak of the COVID epidemics, and all types, and we will give all types of treatment in patients. We do not restrict any therapy except transplantation, but not because we don't have the measures to prevent COVID in our unit, but the current problem is that we have not guaranteed intensive care unit support, because all practically all the ICU resources in my hospital at the moment are occupied by COVID-positive patients. And I have 1/3 of my colleagues working at home for possible substitution of infected physicians or nurses. This is, I think this is important. I have had some infected colleagues, and this backup team has allowed to substitute them and continue the activity. And that's all. Thank you.
Thank you very much indeed.
Sorry, my last slide. Sorry. My last slide is what occurred yesterday in my hospital. So there were more oncology patients than hematology. It's clear because oncological patients are more frequent. But for patients with malignant hemopathies, they were distributed as the frequency of the diseases. Only 3 out of 14 had pneumonia. One of them required ICU, and 2 patients have death. One with CLL, another from myelodysplastic syndrome. Up to now, we have only 4 transplanted patients, COVID positive. All of them are at home and without any need of hospital attendance at the moment. Thank you. That's all now.
Thank you very much indeed. Straight on to Professor Rambaldi. It was lovely to hear those insights from your working environment. Professor Rambaldi, over to you, please.
Yeah. If I can have the next slide. So this is the incidence and outcome of COVID-19 infection in our hematological patients. These are the data that we have been able to collect during the last 4 weeks. And of course, they are very likely to be inaccurate. But this is just to give the audience a flavor of what happens in our patient cohorts. So we have now the diagnosis of COVID infection in 14 patients, and 4 of them already died. And you can see the other numbers with the incident, with the number of patients with myeloproliferative neoplasms. Half of them already died. It seems that some other kind of patient, like lymphoma, may have a different outcome in this setting. So a huge number, an important number of patients already came to our attention being infected over the last weeks. Next slide. And this is the information we have so far been able to collect about the COVID infection in patients who received an allogeneic stem cell transplantation. You see, the first patient was transplanted, the first 2 patients were transplanted in 2017. That is to say that the immune system to a significant quality level, and nonetheless they got infection, and 1 of these patients already died. So as previously alluded by Dr. Mikulska, it seems that there is no difference according to the level of immune suppression in this patient. Rather, we can also speculate that patients who have less competent immune system, those patients can have a less important immunological reaction. That for sure is part of the tissue damage that is taking place in these patients. So the problem is very important for those who have been previously treated with conventional or transplant procedure with an hematological malignancies. We must look and collect all of this data very careful for the near future. Next slide. And in the end, I just like to present an obvious slide which summarizes the EBMT recommendation about patients who are in need of being transplanted. Of course, they should restrict the risk of exposure to infected individuals. They should refrain from non-necessary travel. This is very easy in Italy because everything is blocked. And whenever possible, as Professor Ribera already alluded to, the transplant should be deferred at least by 3 months. And even the patient must take and pay attention at home before the beginning of the conditioning. And finally, what is very important is that the patient should be tested, possibly repeatedly, before the conditioning is started. These are quite simple, obvious recommendations, but they should be kept in mind in the normal, real life, in the setting of transplantation. Next. That's all.
Thank you very much indeed, Professor Rambaldi. Some great recommendations there. I'm just keeping an eye on the clock and how much time we've got left. Let's move on straight to question 4, if I may. So that is about treatment options for patients with hematological disease and COVID-19 in terms of antiviral and anti-inflammatory agents. So it's back to Professor Mikulska, if you would like to take the baton.
Yes. Can I have next slide, please? So what's available for patients with hematological malignancies is the same what's available for all the other patients. Drugs with antiviral activity, they are all off-label. We should know it. In the beginning, there was a huge interest in antiretrovirals, particularly PIs, like lopinavir-ritonavir, and in certain settings substituted for a newer PI due to unavailability of lopinavir-ritonavir. And well, the initial, or not that initial, but well, a recently published New England study showed that they seemed no benefit of adding antiretrovirals to their baseline treatment. We have another antiviral with very promising activity, remdesivir. It's intravenous, the only one to be used intravenously. It used to be obtained through a compassionate use program for single patients who were in severe conditions like mechanical ventilations. Now they are changing the access into expanded access program, but it's currently unavailable outside proper clinical trials. Another antiviral that has been studied is favipiravir, Avigan, which is an oral Japanese anti-influenza drug, which has not been yet approved in Europe, and the trials will start soon. And well, you always look for new molecules, and anti-malaria, anti-rheumatoid arthritis drugs like hydroxychloroquine or chloroquine were shown to have antiviral activity against this coronavirus. So they are currently now being used with the caveat of attention case of GCAPD. We usually provide antibiotic coverage against both co-infections and superinfections. In Chinese trials, superinfections with gram-positives have been frequent. And azithromycin has been given initially as an antibiotic coverage in a controversial French trial with hydroxychloroquine, and they reported very rapid, high rate of virological clearance with the combination of hydroxychloroquine and azithromycin, although some critique has been made that patients had mainly mild disease and there is the risk of QT prolongation. Anti-inflammatory therapy will be addressed in the following speech, but please don't forget also the supportive care that I will elaborate on in the next slide, please. So what we do in our hospital, we give hydroxychloroquine for 7-14 days. We give it also to patients with mild disease who go home. We provide antibiotic coverage intravenously if a patient is admitted. If they go home, we still provide antibiotic coverage with something oral. we evaluate for anti-inflammatory therapy and give it if there is the evidence of systemic inflammation. And to most of immunocompetent patients, we are more discerning in hematological malignancies. And I would also like to highlight the importance of supportive care. So early non-invasive ventilation, this is very important with COVID-19 pneumonia. Almost all our patients are receiving non-invasive ventilation when they are admitted to our unit. And some patients with hematological diseases also needed this support. And as already mentioned previously, since COVID-19 patients are prone to risk of embolism, we provide anticoagulants, and I think it's a very important supportive measure as well. Next, please. So if I would like to sum up what would you recommend to be prepared in their centers, I would repeat that prepare in advance your care pathways, all the ones that we talked about, discuss the procedures with the staff so they are well aware of it, and if they have doubts, they can consult and discuss the doubts. Establish good collaboration with ICU or ventilation service, which might be outside ICU, like it's happening in our hospital, to have early evaluation for the non-invasive ventilation and, if necessary, intubation as well. And it's sometimes helpful to provide the colleagues with your survival estimates for your patients with hematological malignancies. Because once ER or ICU service, they understand that these are patients with high probability of surviving, they will invest more in the terms of ventilation. And last but not least, collaborate with us, with ID team, because data and access to certain therapies, they change really rapidly, and it's very difficult to stay on top of everything. Thank you.
Thank you very much, Professor Mikulska. Very thorough, and again, really interesting to see your insight. So if we could move on to Professor von Lilienfeld-Toal to if you would give us your view on antiviral and anti-inflammatory agents and options for treatment, please.
So yes, I talk more about the hyperinflammation and what you can do about that. And as Professor Mikulska already said, obviously in the viral phase, antivirals may be effective, and possibly one of the reasons why the New England Journal publication on antiretrovirals was negative was that they were actually given very late and with a median of day 13. Now, if you look at this graph of the clinical course of COVID-19, you can see that other than other respiratory viral infections, this disease is actually slowly evolving. And it really has the peak of severity in the second week. We believe that the first phase is the phase where antivirals might work, and the second phase is the phase where hyperinflammation kicks in. And you can see in the graph below that the survivors and non-survivors are actually different in the degree of inflammation, the degree of cytokines they have in their blood or ferritin. Next slide, please. So there is a suggestion that the course of the disease actually has 3 stages, and the first stage is the early infectious stage where there's a viral response phase, and here you can effectively treat with antivirals. And then as time goes on, inflammation develops, and the third stage really is a hyperinflammation phase, which is characterized by a lot of cytokines on board. It might mimic HLH. And there's a risk of vasculitis or thrombosis, as has been mentioned before. And here treatment options are sort of the contrast. So they would be anti-inflammatory. And steroids are being talked about, JAK inhibition is being talked about, cytokine blockage is being talked about. And I think some of them we do have some experience with. Next slide, please. And here, for example, there's experience with tocilizumab, which you might know from the cytokine release syndrome. And 20 patients or 21 patients here have been treated with that, and they actually had a severe course of their COVID-19 disease. And they've been given tocilizumab the way you would give it in the cytokine release syndrome, and they actually all got better. and were all more or less discharged and quite well. And that happened rather rapidly. And it seems that this is an experience that other people are making as well. So I think we might get more data on this, and this might actually be a promising approach. Next slide, please. And something which is probably easier to do is to give steroids, which we do obviously as hematologists quite a lot. Now, for somebody who deals with respiratory viruses, this is counterintuitive because steroids tend to lead to a longer viral shedding and actually prolong the disease potentially, like for instance in influenza, which is why the WHO has actually recommended against steroids in the beginning. But the data coming out from China, as you can see here, a retrospective study, which seemed to suggest that actually maybe in this case, a sort of low dose of methylprednisolone is actually beneficial. So this supports why you might actually use that as supportive measure during the course of the disease. And this is it from my side. Thank you very much.
Thank you very much indeed for that. I was just having a look through the questions that are coming in. Really, really thorough coverage there of so many issues that affect clinicians, hematologists everywhere at the moment in these unprecedented times. I have got a few questions that have come through that I'm just going to throw to the four of you, if I may. And I've been trying to collect up themes because a lot of the questions, as you can imagine, are quite similar. One that's come up again and again is about bendamustine and its use in the elderly and whether it should be, avoided irrespective of COVID disease status. Professor Ribera, perhaps you'd like to take that one.
Sorry, the specific questions. What is the specific question?
The question is about bendamustine and whether it should be avoided in all settings. So it's not recommended for patients with indolent lymphoma. Does that apply to patients in general, or whether they have COVID or not? If you could expand on that.
No. We try to avoid the use of immunosuppressant drugs, even if they suppress mainly the T-cell compartment of immunity, but especially in elderly people, because they by age are at high risk. So I think the combination of age and immunosuppression, even cellular, is not good for this. For the risk of acquiring COVID infection. It's just for this. It's empirical, but most of our measures are still empirical because we are now learning day by day by this infection.
Thank you very much. Another question, I'm jumping around a little bit because I want to get a bit of a variety over to you. Have you heard that clinical trials are being halted because of the COVID crisis? To anyone? Professor Mikulska?
You mean hematology trials? That would not be the question for me.
Okay. But have any of you heard of trials being halted?
Yeah. We have tried to manage and to delay enrollment of new patients into clinical trials because we know that everyone could be affected by this infection, and it is obvious to avoid to have a patient into a trial. But then again, you must make some difference of how important is the trial to offer for a salvage treatment in a given patient. So there is no only one answer to this question. In general, we try to avoid to enroll patients to clinical trials in this period.
Okay. Another one.
If I may just say the German view, I think we're trying to carry on doing clinical trials, and we're trying to find a way to possibly reduce visits and things like that, but to still offer the best possible service. And we know that hematological patients do better on clinical trials if they can be included. So we're just trying to organize this and carry on.
Okay, thank
So
you very much.
what we do in Spain is not opening new clinical trials in order for problems of shortage of drug during the trial, but the trials that are going on, we are still using, including patients in these trials.
Thank you very much. Another interesting one was, are there any recommendations or guidelines for CAR T patients and COVID-19? To any of you?
So I think that CAR T patients have been included into EBMT recommendations. And apart from feasibility, the procedures, the recommendations are quite similar to transplant patients, and that's why they were merged together.
Okay, thank you very much indeed. And a last sort of a general question, which is very broad, I think possibly to end with, and that is, how bad is smoking when it comes to the outcome of COVID-19 infection?
Smoking is always bad.
It's an obvious question, doesn't it? But I had to ask it because it was there. But brilliant. Well, listen, thank you so much. I mean, I think we've covered an enormous amount of information. I hope the viewers, you found that really useful in terms of practical tips that can be applied to help your practice, whether clinical or not. I'd just like to thank the four speakers for their time and their expertise. Really, really fascinating insights that I think hematologists will find really useful. Do visit the websites of the EHA and EBMT for updates. And as I say, this is the first in a series of webinars. So if you want to find out more about what's coming up, keep an eye on those. And thank you very much indeed for watching, and thank you for sending your questions in. If there are any that have not been covered, and I know there have been loads because I've been keeping an eye on them, as I said, the EHA and the EBMT will be following those up and getting back to you. Thank you for tuning in, and hope to see you next time. Thank you.